And we're back. We have Austin Baraki. Austin, for people who aren't familiar with you, can you give us a little intro on yourself before we discuss the topic for today?
Sure. Thanks for the invitation. I am a practicing internal medicine physician and educator, and I think in this space, be it peripherally related to rehabilitation and training and performance and things like that, some folks who may be familiar with some of my stuff will be via the Barbell Medicine company where I work with some friends and colleagues in this space where we work with athletes and general population folks, promoting health, exercise, various lifestyle interventions, and then also have an arm of our business actually dedicated to rehabilitation consults and coaching as well. I think kind of similar to some of the areas that you guys work in. So that's probably the short and sweet of it.
Yeah, Austin is on a ton of podcasts with Barbell Medicine and has been on other podcasts before. And I reached out to Austin to discuss a topic that I feel like I haven't heard a ton from you on these podcast platforms, but I've seen you post about it on your Instagram of kind of these awards you've gotten over the years of teaching and what seems like people are expressing the value that you have either in the hospital setting, in the medicine school of med, like the value you bring as a teacher and as an educator. And there's so many different, and we'll dive into it, but avenues in which you're teaching and different settings that I selfishly wanted to bring you on to know, how you've done such a good job as a teacher and how you've evolved and changed over the years and how it changes setting to setting. So can you touch on at this point, what settings you are teaching in whatever capacity? And then I want to kind of dive into each one and how they're different.
Yeah, sure. Appreciate the recognition there. It's something that I have been doing for a very long time, and it's probably my favorite thing to do, even though most, as you said, of the conversations that I'm involved in are related to other topics, be it, clinical medicine or patient care or training or, any sort of other thing. Actually, teaching and education is my preferred thing to do most of the time. And it's something that I've been doing for a very long time. I can think back to probably like mid high school. I started like tutoring people in topics that they needed help with, and then that continued where I was a college athlete and I had to tutor some of my teammates to help keep them eligible to be able to keep participating in the team, and then that continued into medical school where I was kind of tapped for some various student review sessions and end of course reviews and talks and tutoring some folks as well. And then that naturally transitioned into my postgraduate, post medical school training, where as you gain experience and you kind of ascend the hierarchy from as an intern to a resident to a attending physician, you accumulate learners under you for whom you're responsible for their guidance and education. So it's been a pretty continuous trajectory for quite a long time. And so I explain all that just to illustrate that, like, you've invited me on here to talk about these topics, but the caveat is, like, I am not I don't have like a doctorate degree in education. I'm not professionally trained in educational, I don't know, psychology, whatever that field would be. Most of my commentary, insights, experiences, things I'll be talking about are really just like based on what I've done for a really long time now, my base of experience and all of that over time. So I'm not bringing citations for most of the things that I'll be discussing here today, unlike many of the other podcasts that I'm on, where I do try to bring receipts and citations for the things I discuss. So I would say at this point, the settings and the capacities where I'm teaching are a few different ones. So one involves medical trainees. So I do work at a local medical school where I am involved in the basically the clinically oriented education for preclinical students. So as a clinician, I'm tapped to teach their first year and second year medical students who are, still in the classroom effectively, not out on rotations and in hospitals and things like that, but teaching them clinically oriented topics. So I'm not teaching them, bench science work, but rather I'm introducing, like in a few weeks, I'm going to be delivering a series of cardiology lectures to a class of second year medical students who don't really have any experience with this yet. And I'm going to be the person introducing several of these concepts to them. So I teach first year and second year medical students at that school. Third year and fourth year medical students will often come and rotate with me clinically in the hospital. So that's when they're out of the classroom and they're coming to spend some time with me on the inpatient hospital wards where we're seeing patients together, and they're getting that face-to-face experience with patients. I also work and teach in an internal medicine residency program. So this would be for postgraduate medical trainees who have finished medical school and are in their 3-year residency training for internal medicine. And I sometimes will often have, early trainees from other specialties who have to do, a rotation in internal medicine or something like that. So that's an additional 3 years of postgraduate training, after which point somebody will graduate residency and they'll become an attending physician. So that's one of the coolest things to me, is that I teach that entire spectrum. And I hesitate to say it is anything like teaching from first grade through seventh grade, especially because my mother has been a first grade teacher for decades, and it's very different in many ways, but some interesting similarities as well. So I think that I get to teach this, I'll just say this 7-year spectrum of medical training, from first year medical student all the way through third year resident, after which point somebody is effectively a colleague, which is a pretty cool transition to watch over the years that I've been doing this. So medical trainees is probably the first kind of category of folks that I teach. I'm sometimes involved in teaching colleagues, be it at a dedicated conference talk, or sometimes we have physicians, for example, who come to some of our barbell medicine weekend courses and seminars and things like that. And so I sometimes have physician colleagues or other healthcare professionals who come. And then the barbell medicine seminars that I just mentioned, also we have tons of lay people, lifters, coaches, athletes, and again, healthcare professionals who come. So we have a pretty huge audience who come to those seminars that I have to kind of find a way to communicate to all of you at once. And then I would say the last category of people that I provide education for are patients. Oftentimes I'm sitting face to face with a patient in the hospital setting or in a telemedicine consult or primary care or something like that, and might make a new diagnosis and say it's something that's as common as diabetes, and I might say something to the effect of, "Tell me what you know about diabetes," and it's not unusual to get a blank stare and to not have any understanding of what that is. And so I have to be the person to get that ball rolling of like, okay, this is what this word means, this diagnostic label. Here's the implications it has for you. Here's why we ought to do something about this, why you should care, etc. So that's a whole category of teaching and education of its own.
You had mentioned your mom is a first grade teacher. Do you think this was just something that you naturally were interested in because of growing up with a teacher in your family, or maybe teachers? Or what are your thoughts as to why you're so interested in it?
I have no idea the whether or to what extent that may have impacted me, because I would have been relatively young at that time and barely knew who I was to be able to recognize these things. I'm sure my mom would be happy to take some credit for instilling these things, but it's really quite difficult for me to say that the extent of that. I think that academically growing up, I was, particularly around that period of time, relatively strong and picked things up maybe quicker than average, and that put me in a position to identify that maybe there's somebody else who's struggling to understand this, and maybe I can kind of explain this in a way that makes sense, and getting some positive feedback that kind of snowballed over time. But as far as like the reasons why I like doing this or I enjoy it, I think that most people enjoy things that they are good at. That's a natural feeling to have. But I think many of the reasons are going to be common reasons that you hear from educators across the spectrum as far as why they enjoy doing this. I think you directly observe the impact that you have on somebody's growth and development, right? And in my setting, particularly with medical trainees, the cool thing is thinking about the potential like ripple effects of this, right? Because I'm not just teaching them arithmetic, not to denigrate somebody learning or teaching arithmetic, but rather I see that I'm teaching, say, this trainee, it could be something, a medical condition, a diagnosis. I could be modeling and teaching them a communication strategy that they will then adopt. And I know that as for this medical trainee, they may move forward and start to adopt this and use it with all of their future patients, right? So now I'm seeing the impact not just on this person, but then I can say, oh, this is likely to they're going to take better care of their patients in the future as a result of, in my biased opinion, a good way of doing this or of understanding this or of applying it. And then even from there, I know that this medical trainee is going to grow up and probably going to have some trainees of their own one day, and they're going to be able to teach that on. So it's like this enormous downstream impact that I can directly observe from medical trainees in front of me. through that process, you develop pretty strong relationships with your learners that can be longitudinal in nature. There are a few, mentors that I had, or folks who had an impact. I can think, among many of the attending physicians that I ever worked with, various little things that I identified in their practice pattern. I was like, that's a unique thing that this person does, and I really like it, and I'm going to steal that and adopt it for myself. I can think of a number of little things. This guy, he was the first person who, made me notice the impact that it has to just sit down in the room with a patient instead of to stay standing. This one guy I worked with in the ER 15 years ago, and he would sit on a trash can if he had to. Whatever he did, that was his thing. Another person who I observed how judicious he was with his ordering and application of medical tests. Somebody said, just do all the tests. He's like, no, I'm going to do this for this reason, that for that. So I adopted that into my practice pattern. Another person who had their approach to interpreting and applying evidence, and I stole that. Other communication strategies, both with patients, and then one who I can remember who the way he delivered feedback to me is the way that I have now adopted when I'm delivering feedback to other learners. And so I can think about all these relationships that I had in the past that impacted me. And then now I'm seeing, as I accumulate, approaching now a decade of post medical school experience, I have this growing swath of learners that I've worked with who will periodically reach back out to me, or they'll shoot me a text, tell me, hey, I saw this case, or I did this, reminded me of this time that we, had this patient that was memorable. It could be years ago or something like that. So those kind of longitudinal relationships are also very cool. And the other things that I really enjoy, I think it kind of goes with the specialty that I chose in internal medicine. I like knowing a lot of things. This specialty is enormously broad. It kind of encompasses all of the specialties in one, from a medical side. And it is difficult to be very good at it and to really have a strong understanding of everything. And when I'm put in a position where I have to be able to teach a lot of these things, I have noticed and felt over the years my own understanding of these things has gotten so much better as I have been forced to teach all of these things to so many different types of learners. So, I have to be ready for them to ask me, why does this do this? Can you explain this? What does this medicine do? How does that work? So I have to be able to field those questions on the fly, or at least I feel I should be able to field those questions on the fly. And I deal with all sorts of different learners who are coming in with a different base of understanding that I have to be able to adjust for. They may have a different background of experience. They may have different kind of learning styles, quote unquote, or things that tend to work better or worse for them. So I have to get creative in my approaches for different learners, and that makes me a more skilled educator, I feel like. So it's just been this huge snowball effect. So ultimately, I would say the bottom line is just like watching someone grow is super cool. I can see it in their eyes when something really clicks and they can successfully apply it for the first time, whether with a patient or with an example that I give them. And then especially cool to me is when I can see them build enough of an understanding and confidence to where they're willing to at least try teaching it to others. And then, because I've had some trainees who I've worked with who they didn't come in with any interest in education or teaching, but after working with me, they were like, that's super cool. I want to be able to do that. But I recognize that I don't know enough to be able to do that. So I want to build an understanding of this topic well enough that I can go and teach it to others. And so there's many learners that I've worked with who have now gained and built an interest in education for themselves, which is like the pinnacle, I think, for me when I do this.
Well, I'd love to dive into these different areas because I'm sure there are commonalities and similarities of how you go about teaching and feedback, like you mentioned, but also differences and why there are differences depending on the context and who you're discussing these things to. So let's start with that first grouping, kind of this like medical curriculum. And if you also want to just tricate it if you need to the first and second years, the third and the fourth, and then the residents, sure, if that feels valuable. But maybe we start with the youngest end of that spectrum. What are the things you're thinking of when you're educating them on these clinical concepts and scenarios? And whatever information you want to indulge in that area.
Yeah. So I think that one commonality across this spectrum and really across education in general is trying to get a sense of what is the starting level of understanding that the person has, what kind of background knowledge are they bringing in. because background knowledge in an area is critical for you to be able to kind of scaffold new knowledge onto that and build relational understanding connections between concepts. I am very much not a fan of straight memorization or of like kind of disorganized thinking. This is somewhat unrelated, but if I prompt a trainee or somebody, what's your differential diagnosis for this patient? I do not prefer when they just rattle off a giant list of diagnoses. Rather, I would prefer there to be some kind of organizational structure to that differential diagnosis that shows me that they have an organized framework in their mind that they can deploy as needed when they see this scenario in practice. So getting a sense of where somebody is coming to you from is the most important first step. If you just jump in to start teaching something without having any understanding of that, you're going to do poorly because you're going to either overshoot or undershoot, or you're going to miss people entirely. And if somebody, for example, comes in with inadequate, background knowledge compared with the level that you're speaking with them at, within the first minute, you're going to lose them and you're not going to be able to pull them back in. So at this point, after having done this for a decent amount of time, I can pretty quickly get a read on this with somebody just from having a bit of a conversation and a few upfront questions. This could be as simple as just tell me, what do you know about this topic? And probably within the first sentence and the words they use and how fluent they are in speaking that language of that topic, I can get a sense of, okay, I'm dealing with somebody who really doesn't have much of an understanding, or this is somebody who's like on the level of a colleague that I can speak with at a relatively high level. So that's if I don't know kind of directly the audience that I'm dealing with. If I'm in an auditorium lecturing a group of first-year medical students, especially like this month in August, I'm like, y'all were just college students a couple months ago. You don't know anything, right? That's my presumption. And so I don't really have much of that background knowledge kind of to scaffold new concepts onto, except for whatever basic, college biology they may have, learned. So like they know that like humans are made up of cells. Like that's my only baseline assumption at that level. And so I start out at that level and I try to communicate to them accordingly. And so recognizing that background knowledge, regardless of the level, is important so that you can adjust the level of your conversation and teaching and the complexity and the depth that you go into to meet them appropriately where they're at. And so this is, I would say, one of the more challenging aspects of being an effective educator is having a good enough understanding of the topic yourself to where you can break it down or build it up, communicate the same thing in different ways depending on the level of the learner that you're dealing with. This is also something that can and often needs to be dynamic. So sometimes, you might be communicating with somebody and they might be like, giving you all the nonverbal cues of, yes, I'm following, engaged, I get what's going on. And then you might kind of start to miss them or lose them a little bit. And you have to adjust your your approach or the way that you're communicating this. So it's not only adjusting to the level of the learner, but also in some situations in real time based on your observations of the person and whether they're following along. If you have difficulty observing these things, or if they're not giving you a lot of those cues, right? So that could be due to social relations on either end, one's ability to express it or the other person's ability to perceive it. You may have to actively assess this kind of thing. So asking questions along the way can be a useful strategy to assess, like, did they pick up this concept? Are they able to apply this before I move on to the next one? But even that can be challenging, right? Because I can ask questions at all sorts of different levels. And I don't want that to be a mismatch either, because say I have a first year, second year medical student and I ask them a medical resident level question, they're going to be demoralized because they have no idea, and then they're going to feel bad, or they might be there might be some intimidation factor there because of the hierarchy, power differential, whatever the case is. And so oftentimes I might have to deliberately toss up a couple softballs for them that I know are easy, that they can knock out of the park, to build some confidence, to show that they they're engaged, they're understanding, they're making some progress before I start to build up the complexity of questioning and application from there. So there's all sorts of different dynamics that I suppose I'm somewhat subconsciously paying attention to when I'm doing this, because I'm saying these things to you now and I'm like, I've never really talked to anybody about this. This is just like thinking back. This is like what I'm doing. And then depending on the so that was mainly for, the context of the preclinical students. once we're into the clinical realm, there's the additional kind of challenge and stressor of the actual clinical environment. And so paying attention to the context is important. And so what do I mean by that? For example, are we in a patient's room? If we're in a patient's room standing in front of a patient, asking a medical student some questions is very stressful, right? They may be intimidated, they may be terrified, they may not want to get the question wrong in front of the patient. My question may lead them, they don't want to accidentally say something that freaks the patient out. Like there's all sorts of things to consider in that room, right? Another scenario is with residents, because medical residency, I don't know if you've heard, is very difficult, extremely taxing. It breaks a lot of people over the course of that time, just from the workload, the stress, the hours, the patient volumes, 24-hour call shifts, sometimes longer, et cetera, depending on your specialty. And so, for example, I'll sometimes have a resident who is on the tail end of a 24-hour shift, and their brain is mashed potatoes by that point. And I have to recognize, like, okay, this is a really important thing that we're talking about with this patient on rounds, but I need to get this resident out of here. This is not the time for me to be doing this teaching, because if I start to teach, they are not in a place where they can receive this information effectively. And so sometimes I'll just tell them, I said, I'm going to put a pin in this. You're going to go home and sleep. And then when you come back, we'll end up coming back to this. And believe it or not, this is not the norm in a lot of settings, including in my own prior experience. I would have staff who seemed completely oblivious to the fact that I was, dead inside after a long shift like that, and they would jump into a long, unnecessarily technical, detailed discussion that was probably also beyond my level of understanding at the time. So mismatching the education to my level of understanding at the time, not paying attention to the context, not recognizing that I was not in a good learning environment to actually receive this information. So all of those are examples of things across the training spectrum that I am kind of taking into account. What level are they coming in with? Adjusting my communication to that, adjusting based on real-time feedback during the session. And then once we get into the clinical world, paying attention to the context, be it the patient's room that we're in, or is this in the ER? I'm not going to do a lot of active teaching during a code blue when somebody's like getting CPR, dying. We're just like doing stuff, right? And then based on their own situation in terms of fatigue, stress level, timing, things like that, because it may not be the right time to actually land with your teaching. So I would say that that's probably the main things that I'm thinking about in that context. If there's anything else, it would just be I am a big fan of trying to use spaced kind of repetition of important concepts and making them as clinically relevant and applicable as possible. And so what that means is, let's say that, on the first day of this rotation, I taught my trainees about, shock or hypotension or something like that, right? Each time that in the subsequent day or days or week that we see a case of that, I will explicitly use that as an opportunity to tie it back to that original discussion. And so, that ends up being a way to reiterate, reinforce, and go over the topic again, and they're seeing it in front of them and the relevance, and that kind of makes it more real to them, makes it more interesting. And by the end, I might get to a point where I might start quizzing them a little bit after we've gone through this 3-4 times with subsequent patients, because it might be a topic that we see relatively often. And then as they get more comfortable with it, they start being able to explain it back to me, and I will celebrate that, high five, well done, you're clearly showing improvement, understanding, giving them that kind of encouragement and pointing out when they are demonstrating explicit improvement in their knowledge and understanding. And so I would say that those are probably the main strategies that I'm using in that clinical setting. So I'd say that's probably the first bucket.
To those first and second years, you made it sound like it's that traditional auditorium format where it's a larger group of individuals and they're not in the clinic. Is that correct?
For the most part, yeah. We do sometimes do little small group, clinical problem solving labs and things like that, but that's still not in a clinical setting. We might just be in a little tiny workroom in the med school, but otherwise the lectures are mostly auditorium style. Yeah.
Yeah, I didn't go through med school, but my perception or outside view is a lot of those auditorium classes, a lot of kids either won't show up because they'll just study on their own, they'll go through Anki decks, etc. How do you keep med students in that bigger auditorium format engaged compared to the clinical setting where they have to because they're in the thick of it? Have you noticed any difficulties with the auditorium format?
Yeah, totally. I think the auditorium format, at least nowadays, typically involves some form of a projection, like a PowerPoint presentation or something like that. And that is the death of effective teaching, I think, in many situations. So uh, if you have an educator who um, is very, very, very reliant on a PowerPoint presentation, and they pack each slide with way too much information, the text is too small. Anytime I hear somebody giving a talk and they show a slide and they say, like, here's this graphic, I'm sorry it doesn't really project very well, that's a tip off to, like, you did a bad job making this presentation. You probably shouldn't have used that graphic. If they're reading off of the slides, if they're not showing how this is relevant or important or why anybody should care about this, those are all the ways that auditorium lectures are minimally effective. And so I deliberately avoid all of those things. So if you look at any of my sessions, so I'm going to be giving 3 cardiology lectures in about 2 weeks to the students that I teach. My slides, there is no text anywhere throughout the entire presentation that is any smaller than about 28 point font size, which minimizes the amount of text per slide. That means that I have to actually know what I'm talking about, so I'm not reliant on my slides or reading them. That is just providing some kind of organizational structure so the students see where I'm going with things on that slide. I do not read anything off of them. It's just a cue, arguably as much for them as it is more for them than it is for me, because I know this topic really well, right? So ideally, that's probably the starting point, is like, does your educator know what they're talking about? Ideally, they should, if they're going to be teaching it. These are talks that you could wake me up at 3 in the morning and I could sit up and I could just give this talk because it's something that I understand that well, right? If I'm very reliant needing to read everything, then I don't actually know it. And perhaps I'm not the person who should be giving this talk, right? So I would say that that's one thing. Another is I use strategies to, again, make the topic feel more real and relevant to them. I am probably in a little bit more of a convenient position to do that as a clinician educator compared with traditional, PhD basic science educators. Because if you're in medical school or you're in physical therapy school, right, you're there to become a clinician. Of course, you need some basic science foundational knowledge that you're going to have to build, but you're there to become a clinician. And so that's the stuff that you are going to care the most about, not like pipetting things and running Western blots yourself, but rather, how does this impact real life cases and things like that? So I am often able to, I have my kind of lecture structure, but I'm often able to just kind of like riff a little bit during the talk and pull in, hey, last week I saw this case of this very scenario we're talking about, and here's what happened, and this and this and this, and I can see them just like locked in and fascinated when I'm able to give, because they haven't seen any real patients yet with any of these things. Meanwhile, I'm like, yeah, I just saw this patient in cardiogenic shock who was dealing dealing with this very complication that we're talking about today, and I can show you an image of what their echocardiogram looked like, and I can point out, here's what we saw, and here's why I was thinking about it this way. And they're like, they can see that as kind of like the aspirational end state that they're working towards, as being able to think this way, understand this, work with these scenarios and recognize and manage them. So I would say that effective presentation design is one thing that I'm very focused on. Minimizing my text and not reading, and using multimedia, be it auditory, visual, stuff like that, to help to augment the things that I'm saying. I will also, similarly to the last section that I was mentioning, speak in a different way to different classes, right? That is both in terms of the jargon and complexity. So I markedly reduce the kind of clinical jargon that I'm using with, say, first years. It'll build up a little bit with second years. My pacing is very deliberate in terms of the speed that I'm going through things. for things that are more complex, that I recognize are more complex, I will slow down and I will say it multiple times. Whereas with things that are, much more simple, more conversational things, I might go through that at a normal pace. So these are all things that I'm using. And, I've taught in various kind of setups of the auditorium style lecture where sometimes students were required to attend. So I gave a talk a couple weeks ago to a full auditorium of 200 medical students who were all in attendance. I was very fortunate for them to all be there and enjoyed that. And so then I love getting that real-time feedback because I'm making eye contact throughout the room with these students, and I can kind of get a read on. It's not like every single person in there is absolutely locked in the entire time, but I can get a sense of the vibe in the room, right? Whereas where I've done like asynchronous pre-recorded lectures where I'm talking to my computer screen and then just post a video, I don't get quite as much of that. In that scenario, I am even more deliberate about my pacing and my language and repetition and things like that, because I know that I'm speaking to an audience that I'm not able to get any real-time feedback from, which is an additional challenge. So I would say that that's kind of the main aspects of the auditorium lecturing that I tend to focus on.
Before we move into the next section, which will probably be kind of the colleagues arena, do you have any reflections on, okay, these were things I definitely have adjusted within teaching this kind of 7-year range of first years all the way to residents, things that you reflected on that you've definitely adjusted, or things that you just see that are commonly done, and you've already alluded to it, but like common mistakes that you're like, these things probably should be different?
Yeah, I mean, over these years, I feel like the biggest thing is, since I've worked with so many more learners at this point, I couldn't even hazard an estimate of how many it would be, just because of the frequency of rotators coming through. But having worked with so many people, I've been forced to develop a lot more kind of creative methods to describe and explain things. Um, Often, this is something that I always find really interesting. Sometimes I'm explaining a concept, and it might be the way that I usually explain it, and I might get a sense from the learner that like they're kind of only sort of following along this particular way that I'm explaining it. And I've had so many times where, like, mid conversation, just out of nowhere, my brain just like generates this completely new analogy or way of explaining this, where it's like, I've never thought about it this way. Let me try explaining it with this relational kind of connection or this analogy. That happens a fascinating amount of the time, and I wish I had an understanding of like what on earth is going on in my brain, where I'm like speaking to you, engaged in conversation, and then just like out of left field, I'm like, try this, and this whole thing, this analogy for this situation that you've never really thought of before, and I'll try that, and sometimes it hits, and sometimes I have to kind of again go back to the drawing board. But the only way I think that you can do that is probably some degree of just, I guess, like skill, I don't know, but the most important thing is having an exceptionally good understanding of what you're talking about, right? And so when I first came out of training, my first year as an attending physician, for example, I had a much more limited scope of experience with teaching clinical medicine, right? Only that which I did as a resident. And so I had a more limited set of strategies and experience, and a more limited understanding of the very things that I was tasked with teaching. This is a unfortunate secret about medical training, is you finish your residency training and you think you're going to graduate, be an attending physician, and you're done, and you know what you need to know, and it's like that's when the real learning tends to start. There's so much. I feel like I've learned more since finishing residency, both from an experiential standpoint and from my own self-directed study, as I learned in formalized medical training in school and residency. And so building that knowledge base and you're improving your understanding allows you to communicate and teach these things more effectively. And then by teaching, you also strengthen your own understanding, because you're going to be faced with learners who you explain something and then you hit a dead end with them, or they might ask you a question where you're like, oh, I actually am not able to really effectively answer this question, which means there's a gap in my own understanding, and I better go fix that for the next time, right? So I work, every month I spend 2 weeks on the inpatient wards, and then I get a bit of break off, and I might have a whole new team and set of learners. And so there are certain fundamental topics, for example, in hospital medicine, that I end up having to teach essentially every single month. And so you could say that, say for the past 8 years or so, every single month I end up teaching certain foundational topics, right? Certain electrolyte issues, how the kidneys work, how the heart works, infections, antibiotics, all these other sorts of foundational topics. And if you think, hey, I do it every month, basically like 12 times a year for the past 8 years, that's how many repetitions I've had at going through this with a set of learners in front of me, each of whom is coming in with a different level of understanding, needs to get to a different level by the end of their rotation, because some are third year students, some are interns, some are about to be colleagues, right? So I need to communicate to all these levels in an appropriate way and adjust based on what's going on with them and their kind of preferred learning style and things like that. So my ultimate answer to your original question, just like changes, I would say, is really just having more strategies at my disposal. But really that came from getting a better and better and better understanding of the very thing that I'm trying to teach. If I had to think about other, differences, I guess I noticed that I'm more careful and deliberate in the way that I ask questions of learners, for example. Um, in a sense that I don't want to set them up to fail. I want to challenge them, but appropriate to their level, right? So if I'm completely disregarding their level, I might ask them something and they might feel terrible. They might be, panic, anxiety, just again, because I recognize like the difference between a first year medical student speaking to like an attending physician. There's like a huge gap there, right? And so I could wreck a student if I said, the wrong thing, or if I asked them something that is completely inappropriate. And so I am much more deliberate and careful with the way I ask questions to set them up, not universally just giving softballs to everybody, but to target things more appropriately, match their level a bit better, and giving them that encouragement and positive feedback kind of throughout the learning process along the way, to point out and celebrate and show them that they are learning and getting better. Yeah.
You had mentioned a while back that there was someone where you had taken, oh, they give feedback really well, I'm going to adjust this. With this group of individuals or this range, how do you provide feedback?
Yeah, so I've seen all sorts of different methods of giving feedback, ranging from great to absolutely awful over the years. And I think it's, I wouldn't say it's a completely unique, earth-shattering method, but much like if I'm having a conversation with a patient about something, or if I walk into a hospital room to see somebody for the first time or on rounds on a subsequent day, I try to get them talking first. And so that's the same thing that I typically do in the feedback context. This person may have preconceived ideas about what I think about them. And so I don't want to just jump in and just start either wrecking them if they didn't do well, or giving them exceptionally good feedback if there's some discordance there, basically, right? So in the same way that when I'm teaching somebody a topic, I want to get a sense of like, where are they coming from? What foundational knowledge do they have that they're coming in with? I might, start out, tell me what you know about this topic so I can get a gauge on that and then adjust my conversation appropriately. I like to get the learner or the trainee talking first. And so that might be something as simple as, tell me how you think this went. Tell me, kind of like a self-assessment, right? Because then I can get a sense of what's this person's level of insight into their own performance. Because I've seen concordance there where I feel like I did pretty well, and I also think they did pretty well. You can see, I kind of struggled with this and that, and I think I can do better. I didn't do great with this. I'm like, okay, internally, I'm like, yeah, I agree, but how am I going to deliver this, tactfully? But the tougher ones are the significant discordances, right? Where they're just like, yeah, I crushed it. And in my mind, I'm like, you definitely didn't crush it. And so it kind of prepares me for how I'm going to deliver what my feedback is, because that requires some adjusting based on where they are, because you don't want to just take a wrecking ball to their existence if there's some discordance there, right? So that's the first thing. Much like with a patient, tell me, what's going on today, or tell me what you know about this, or tell me your understanding of the plan, or something like that, and then I will just shut my mouth and let them go until they're done, giving them that kind of nonverbal, encouragement to keep going. Tell me more, etc. I'll do the same thing with a trainee. Tell me how you think this went, and then I'll shut up and let them talk. And sometimes that's unexpected for them, and they might not have thought that they needed to go on for a while. So again, I'll just encourage them until I get a good self-assessment kind of thing. And then I'll chime in and tell them my own observations and kind of show that either alignment or lack of alignment between the two, but doing it in a way that is, again, not crushing to the person. And then even if they did really well, seeing if we can kind of collaboratively talk about what their next steps are, what remains for them, because this process never really ends. What are the aspirational things that they can work towards next, if they want to, move up to the next level from wherever they are.
Let's transition to colleagues and similar questions in regards to how are you adjusting your teaching style, your education, and your language with your colleagues?
Yeah, this is one where I would say the most important aspect is similarly understanding who my audience is, because colleagues itself is a relatively broad category, right? It could be physicians, it could be internal medicine physicians, it could be hospital medicine physicians, it could be specialists from other medical fields, it could be surgeons, it could be somebody in an entirely different realm of medicine, like a obstetrician. Like if I'm speaking to my wife about something in my specialty, I'm going to speak about it a bit differently, right? Or it could be somebody else in the healthcare space, in the field, right? So having a good understanding of who your audience is really applicable across this entire spectrum, right? So if I'm speaking to a hospital medicine person, I'm like, okay, you do exactly what I do. There is a certain level of assumed, foundational knowledge that we share here. And I'm going to proceed under that assumption until or unless I actually see any evidence to the contrary, which is rarely going to be the case if we actually have the same job, right? Whereas that assumption of foundational knowledge is no longer applicable the further you depart away from a colleague who does the same job. Again, if I'm speaking to an obstetrician or a pediatrician or an ophthalmologist or something like that, their foundational knowledge is increasingly separated Venn diagrams from mine in terms of the common language that we can share in between. And so, there are probably some physicians from other specialties with whom I would speak to at a much lower level, not out of disdain for their intelligence or anything like that, but rather just because we're not on the same level of shared understanding here, and we need to establish that before I can start to build on it. And so I would say, if to the extent I'm giving a talk where there's like slides or any other thing, all that same stuff applies as what I said in the auditorium section. But with colleagues, it's overwhelmingly going to be understanding who my audience is and like, why is this person here to listen to me so that I can make this relevant, right? Because there's no reason why an ophthalmologist is going to come and listen to me talk about decompensated heart failure, because fundamentally that is not a condition they're going to see, treat, or care about arguably ever, right? No different than me going to an ophthalmology conference and listening to advanced retinal surgical techniques. I should never be in a position where I'm holding anything sharp anywhere near anybody's retina. That is not within my skill set, nor do I want it to be. And so having a sense of like, what is this person doing here, and what is the kind of the objective of this discussion, this conversation, this session, so that I can both meet them where they're at in terms of their foundational knowledge and make it relevant so that they care instead of tuning out, looking at their phone, taking a nap, whatever the case is. And that's, universal across this category, but I would also fold it into, when we teach, for example, our barbell medicine seminars. Like I said, that's probably the widest array of people that I have to teach at once, right? So a first year medical school class, pretty, homogenous. Internal medicine inpatient ward team, yeah, it's just a couple of years of trainees different, but they're all doing the same thing, learning the same thing. But at these seminars, I mean, we've had physicians, surgeons, physical therapists, other rehab professionals. We've had coaches, personal trainers, just athletes. We've had people who have literally never touched a barbell before come to our seminars, and they're like, I heard you guys are the people to learn from. We're like, damn, nice choice. I wish I could have started, day one here. And so that is one of the most interesting challenges, is how do I communicate this whole weekend's worth of material that we teach on health topics, training topics, pain, injury, all this other stuff that we do in a way that does not way overshoot the newbies and does not bore the more advanced people to tears, whether the coaches and athletes on the training front or whether the physicians on the health front. And so that's one of the more fun challenges that we have is how we do that. I don't even know if I could just like verbally explain how it happens, but it does, and we generally get pretty positive feedback on those seminars. But obviously, we also have some degree of selection bias just in terms of like we have attendees who are interested and enthusiastic already, which certainly I don't discount the benefit of that in terms of audience engagement. But the way we communicate these things is a very interesting challenge across that broad of an audience. But that's really the best tip: is know who your audience is and try to communicate in a way that meets where they're at in terms of their foundational knowledge and makes it relevant or real for why they're there.
I think one of the first videos I saw of you teaching was a recording that you had to, I think it was a group of internists. Maybe it was when you were still in San Antonio on sarcopenia. And you had mentioned maybe it was a podcast about in that specific context, you were kind of almost throwing a lot of research at that group because that context that's beneficial or that's providing some value. One, do you still agree with that? And can you speak to times when that would be beneficial?
Totally. Yeah, I remember the talk you're referring to. That was a talk given to my former residency program that I was invited back to speak at. So I had a group of residents and some of their faculty in attendance at that talk. And I think, I would probably stand by that idea or that statement at this point, such that, when I talk about knowing your audience, it also not only is referring to what sort of foundational knowledge do they have coming in, but also what kind of ways of knowing are most likely to resonate with this audience in terms of their epistemology, if I'm trying to convince somebody of something, make a case for something, change somebody's mind, right? Shout out to the book that I refer to all the time, How Minds Change, knowing that process for people, what sort of evidence is most likely to resonate with somebody, then that is the most useful thing if I'm up there to make a case for something. And so for that sort of on this spectrum, relatively more advanced clinical audience, then data is what's going to make that case, right? In that setting, just telling a story, for example, like my grandmother, stopped being very active, and I just noticed she started to get weaker and weaker, and she got some health problems, and she fell, and then, fractured her hip, and unfortunately that led her to pass away. Like, yeah, that's an unfortunate story, but that is not something that in that setting is going to, radically change people's minds on this topic or really educate them in that setting, because they already know that this happens, that they deal with that kind of thing every day, right? The kind of evidence that needed to be provided to make a case in that particular context is data. And so those are people who, if you see an impressive chart, that is something, especially a series of charts, if I can overwhelm you with data, not only to show that like I understand this very well, I have a very exceptionally strong case to make, and here's the strength and consistency and of that evidence, then that is something that can really resonate. And that can end up being the real take home of the talk, right? So if you're giving a lecture for an hour, I mean, people are not going to obviously absorb and retain everything you say during that hour. You only have a few key points that you're going to be able to get through into people's minds. And so that's why when I'm teaching, if there is a key point to be made, I will repeat it and repeat it and repeat it. Anybody who's been to one of our barbell medicine seminars will recall, on certain topics of teaching, certain phrases that I will say over and over again in order to convey the key point. It might be in that lecture or it might be for the entire weekend. So to give an example, when we're talking about certain health-related conditions like the risk of cardiovascular disease, the certain risk factors that contribute to it, they contribute to that risk by way of a cumulative lifelong exposure to that risk factor. So in other words, if you have obesity, the longer you have obesity for. If you have diabetes, the longer you have diabetes for. If you have high cholesterol, the longer you have that. Same with blood pressure, same with these things. So people hear me say that cumulative lifelong exposure phrase like a dozen times throughout that day. And that is the way I get them to understand, like, okay, all of these things are what matter. The more of them I'm exposed to over my lifespan, then that confers the main risk. So what's the logical solution to how do I handle these? Address them as early as possible in life so I don't have that lifelong exposure to this problem, right? And that's the key take-home message that I want to deliver. And so in this kind of a talk to a clinical audience, I was giving data after data after data after data, all indicating, various things about this topic. In that context, it was sarcopenia, that all kind of converged on kind of almost natural conclusions. Like, I make it so that you could not possibly conclude otherwise, but to recognize that this is an important condition. There are preventative measures that can be effective. Here's why we should care about this, and we should care about it earlier in life. And if you can take that home from the talk, then I've made my case. But there are certainly going to be other audiences for whom that approach is not going to work, right? Audiences who do not have that scientific understanding, audiences who are not able to, confidently interpret a graph. Like, there are people who you could show graph, and I don't know what this is trying to tell me, right? Not to mention that oftentimes when those are presented, the slide is designed horribly, and the text for the X and Y axes is too small, and you have to caveat it and say, "I'm sorry, this doesn't project very well," and then you embarrass yourself if you're if you're the lecturer. So this is just ties into knowing who your audience is. What case are you trying to make? What are the objectives? And then kind of what strategies are most likely to resonate. So in some, like, you watch a TED talk or something, right? Those are usually given in some kind of like a narrative storytelling form, because for the lay audience, stories work, right? Both in this context, like I would say TED talks, generally pseudoscientific context, or certainly in like the political context, right? If you go and you watch like political speeches and rallies and things like that, they're telling stories, right? They're kind of honing in on a different aspect of the psychology of the audience, right? Whereas in this clinical context, or if you go to a grand rounds lecture, or if you go to if I go to the American College of Physicians conference, in the spring every year, and listen to a talk on the management of some condition, I'm hoping that they show me data to convince me that I should be doing this differently than I already am. And if they don't show me data, but they just tell me a story, I'm probably not even sitting through the entire talk, because I'm like, that's not why I'm here, right? So all comes down to knowing your audience and their kind of epistemology, and you can adjust accordingly.
This isn't necessarily teaching related, but to this group of your colleagues, let's say it's maybe it's the residents, maybe it's the nurses that you're working with, the PAs, other hospitalists or internists. Are you, when there's conflict and you're trying to provide feedback or you disagree, do you have recommendations or strategies when it's maybe a one-on-one format, or when it's these scenarios where it's kind of in the moment, and how do you navigate those interactions with colleagues?
Yeah. I think the first thing is having some degree of, I guess, I don't know if it would be considered like emotional intelligence or insight or something like that. But when there's conflict, I mean, the natural response of a lot of humans is like kind of bristling. And then I guess there are a couple phenotypes. You can either just like get aggressive, or you can like, want to run away and escape, be super non-confrontational. Just recognizing those kind of innate habits or tendencies, whatever that is for you, right? If you tend to get defensive, if you tend to get aggressive, if you tend to raise your voice, argumentative, like, you have to just muffle that. You have to just shut that down, which is very often easier said than done, for sure. But I effectively think of it as just, I'm trying to just shut down any ego that I have, or defensiveness or argumentativeness, just like poker face through it, and then just try to get a sense of where that person is coming from. And that may be something as simple as just, can you explain to me why you think that, or explain to me how you got there, right? And then maybe along the way you can get a sense of like, is there a spot in their reasoning that that you've identified, kind of like the lesion in their thinking, like this is where this is where we're diverging, for example, But really, I think that, if you start out with that kind of defensiveness, argumentativeness right away, then you're doomed in that situation. So it has to be, shutting down any sense of pride that you have, because really, what's the point of that? Like, in the grand scheme of things, it doesn't actually matter. And then getting a sense of where the person's coming from and how they got there, and how much does it matter that you end up actually hashing this out, right? There are some things that truly are not worth the the argument. Like, is this actually worth going through this battle? Is there some sort of reconcilable position or not? And then the most important thing, I think, is, aside from like actually having a relationship in terms of with this person, makes it helpful, but are you even operating with a shared epistemology, right? So this comes up a lot in all sorts of conversations these days, right? So I could present data to another person on a particular topic. Maybe it's some sort of current, like, socially or politically controversial topic, and I might show them some data. And they are somebody who does not operate based on a value of data. Rather, they go on vibes or feels, or or just what their gut says, or anything, or truthiness, to quote an old Colbert line from a long time ago, right? So that is a conversation that is unlikely to be very successful, because you are not communicating with that kind of shared epistemology. And all of this, again, I feel like I'm essentially keep quoting and referring back to McCraney's How Minds Change, which I'll cite again and recommend people read if they want to get better at having these kind of conversations with people. Assessing, like, what is this person's level of confidence in their opinion? What justifies that level of confidence? And are they able to articulate or explain, like, what sort of thing would be necessary for me to actually, what would alter that level of confidence, right? Is it evidence? Is it I'd have to see this happen? Is it, or no, there's nothing, I'm just, this is what I believe and it is what it is, in which case, probably not worth going through that process. Fortunately, that does not happen very often for me, like in a clinical scenario, because again, in a clinical context, in the hospital with colleagues, etc., most of us have some kind of a shared epistemology, to where you can reason through something either based on fundamentals of physiology, pathophysiology, pharmacology, whatever, to make a clinical decision, or data if there's research into the question. But certainly there are some situations where people might come to different conclusions based on slightly differing or significantly differing interpretations of data. Or they might say, I recognize what the data says, but based on this patient's values and preferences and things like that, I think that I would advise going in a different direction or something like that. So that's just kind of the art of clinical practice, clinical decision making, the classic, pillars of evidence-based medicine, incorporating all those different things, not just the data, but clinical experience and patient values and preferences and things like that, that can lead you to sometimes diverging conclusions, or recommendations or something like that. There are oftentimes, for example, scenarios where I'm consulting with a patient and they might say, I saw my doctor for this thing and they told me this, and I wanted to get a second opinion from you. And I might disagree with that, right? Most commonly, this is like, they got an injury, they saw a doctor told them to stop lifting. So they wanted to, mom told them to stop lifting, so they came to dad so I could tell them that they could keep lifting, right? Now, I have my way that I got to that position and they have theirs, and I feel like I can support mine. Maybe they feel like they can support theirs, and maybe that's more or less reconcilable for various reasons. But so that kind of context matters quite a bit, and recognizing all the variables that go into how people get to their positions is useful.
Let's transition to what you had alluded to as the widest spectrum of audience, which is the Barbell Medicine seminars. You kind of already noted that you don't really know how you're juggling talking to the other doctor in the room or the person that's never lifted, but I'm sure there are things that you're consciously doing in that heterogeneous of a group. Again, similar questions, like how are you formatting the information? What's different in this group and setting compared to the medicine and colleague sector?
Yeah, I think it involves going into the talk with a good sense of what are the objectives, what do I want people to take away from this, right? What is the whole point of this discussion? It's not just because I want to hang out with some people who are into lifting, right? There is a point to this discussion. What am I trying to convey? And then that message should be kind of like a theme baked in throughout, right? And so basically, I am quite confident that during these talks, there are certainly some elements that will overshoot the understanding of some members of the audience, and some that are undershooting in terms of boring the clinicians because they're like, yes, I know this. That's unavoidable when you have that, right? There are some elements that'll go in either direction, but when I zoom out and look at the talk as a whole, I can feel much more confident that the key messages and themes that I wanted to get through have been appropriately delivered, and essentially everybody got something out of that talk. That's probably the best that I can do in that context, right? So, for example, I mentioned the big theme of that cardiovascular lecture, right? To the extent we want to reduce the risk of cardiovascular disease, take a kind of a preventative standpoint, we want to minimize your lifelong cumulative exposure to all of these risk factors. What are those risk factors? Boom, 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 boom. And here are the approaches to actually mitigate those as much as possible as early in life. There might be some new things to some of the clinicians, strategies. They might not have recognized certain things that we can do from a lifestyle standpoint, for example, or from a medical standpoint. And then for the lay folks, that entire concept of like, oh, I thought heart attacks was something that only people in their 70s got. I didn't realize that, this risk starts accumulating from the moment you're born, and maybe I should do something about this earlier in life to get my blood pressure down. Because even if a 20-year-old needs to take a blood pressure medicine, they need to do what they need to do, right? That might be the new take home. But ultimately, it's all centered around that like kind of converging theme that I'm trying to convey. We have the same thing in like our lecture on obesity, trying to remove some of the stigma and the moralization around it, and have people view it through a different lens and how it can be intervened upon and things like that. In the context of training, that's the other side of the spectrum where it's like probably most of the physicians actually don't know very much about this at all. And the lay people may or may not know as much. The coaches are going to be the people who are, have arguably a little bit more expertise or experience in that realm, right? So that's a situation where it's like, okay, we really have to define our terms here and establish, lay the groundwork for that shared understanding, right? What is exercise? What are the goals that we're working towards from a standpoint of strength or lean body mass, cardiorespiratory fitness? What are the fundamental, programming variables? How do we define them? How might we manipulate them? This is groundwork that has to be laid before we can start having kind of higher level conversations about approaches to training towards particular goals. And much more of that, physicians oftentimes are just like, yeah, I didn't know any of that stuff. And it's like, yeah, I know. That's probably a good thing you came to this talk. So that's kind of my sense, is that different talks are going to, you're going to have different components or subgroups in your audience that are kind of more or less coming in with more or less of a foundational base of understanding based on the talk. And I'm trying to basically just like catch everybody and find a way to elevate their understanding by the end in line with the themes that I want to convey. And so there's, again, some acceptance that like, yeah, I might, when I'm talking about something that all the physicians are already going to know, like, yeah, you can, monitor people's hemoglobin A1C for diabetes. Yeah, if I see a physician like on their phone during that section of the talk, I'm not terribly surprised, right? But during other sections, it might be the coaches who are just like, yes, I know how, I know what training volume means, but the other people who don't have an understanding of that, they're the people who I'm catching with that. But by the end, the goal is ultimately to catch and connect with everyone in the room in some way, which is kind of what I'm watching for as I'm talking and making eye contact and seeing that kind of nonverbal kind of, responses out of people that I'm intuitively noting along the way.
Let's go to the final group, patients. You've mentioned some things with the patient interaction, but again, where are you framing this education piece when in the hospital setting or your telehealth consults?
Mm-hmm. Yeah, I think key, again, as with the others, is understanding my audience, right? So I might have a conversation, and as with when I'm giving feedback, I try to get the patient talking first. So I might go in, what's going on today, or what brings you in today, that kind of a usual question. Or it might be I'm seeing them on a subsequent day in the hospital, and I'll start out with, tell me, either how you're doing, or tell me what you know about the plan. Things like that kind of I aim to get them talking first, and then I shut up and I just kind of listen. And listening in that situation allows me to do a few different things. It allows me to assess their understanding of what's going on. Sometimes I get a blank stare. I have no idea. Sometimes I might get an answer in a different language, and I realize that, oh, this person does not speak English, and everybody else who's been speaking to them in English, they've just been nodding and smiling, which sometimes happens. Sometimes when they're talking, I might note that they use a medical word, which is an immediate tip-off to me. And so that might then prompt me to ask them, what do you do? And that is often where I'll hear, oh, I'm a physician, or I'm a PA, or I'm a physical therapist, or what. They work somewhere in healthcare. And so that's immediately a sign to me that, okay, now I have a better understanding of who my audience is, and I can speak to them probably at a little bit of a different level, right? Um, this just happened actually a week or two ago. I had a young male patient admitted for a flare up of, unfortunately, has multiple sclerosis. And when I was asking what was going on, how he was feeling, I think he said something I think he used the word lesion or something like that. And that's all it took. And I was just like, you use that word. What do you do? And he actually did not work in medicine. He did a different job, but he said, but I'm actually currently preparing and studying to go to medical school. So I was like, cool. Not only is that helpful for me to know, but now I can establish much better rapport with this person, because I know what his goals and aspirations. He wants to, one day be doing my job or something like it, right? And so I can be encouraging and, that's awesome, that's cool, and I can speak to him on a level that kind of hypes him up a little bit, makes him feel like he is, a more active kind of player in this situation. I can use some doctor words with him. I can maybe, even if I'm doing his neurological exam on him, I can actually maybe teach something like, here's why we're doing this. Here's what this H test is teaching me with your extraocular movements or something. And that's just a way to, not that I'm intending to educate him on the neurological exam, but rather to it's a good way to build some patient rapport, and then patient rapport can pay off in all sorts of ways in terms of better patient outcomes, and when it comes to making difficult decisions and planning and things like that. That's a good kind of thing to have built up. So understanding the audience through that way is probably the first and most important thing that I would do. And I do that by getting them talking first, and then just shutting up and listening and paying attention to verbal things, nonverbal things, all sorts of other aspects of how they're expressing themselves, to kind of localize where they're at and how I can best meet them in terms of my communication strategy. There are some times where, I hate to use the phrase like dumb things down, but effectively, I'm trying to just like extremely simplify, what I'm talking about, in order to meet that person's level of medical or health literacy. Whereas other situations, like, might have a cardiologist I'm taking care of for, a heart attack. And then obviously it's like, okay, they know what's going on here, and I can just have a much more high level conversation about this. The other aspect, aside from knowing the audience, is recognizing and respecting the context that we're in. And so that's similar to when I was talking earlier about my residents and the stress levels and work hours and all sorts of other things, and like, when is the right time, and how do I go about this conversation most effectively. Here, recognizing and respecting the context relates to, for example, a few of the settings that you outlined. Am I doing this on a telemedicine consultation where the person could be on the other side of the country? Am I doing this in a hospital setting where the person's face to face with me? Am I dealing with a language barrier, which in itself introduces some challenges? Am I communicating with them in their language? Like, am I speaking to them in some Spanish myself, as I sometimes do? Or do I have a translator? Is that translator in the room? Or is it via a phone? Or is it via like an iPad, which we sometimes, all those things kind of change the communication dynamics a little bit, right? And then really the topic of conversation is really important here. So the one extreme example is like, are we having like an end of life conversation, like a hospice conversation? This patient's dying, I'm delivering a cancer diagnosis, something like that. I do that all the time. And those are obviously much more, intense, somber, types of meetings, where oftentimes the patient's there, they might be lying in the bed looking very ill, might have some family members there in person, or they might be kind of on speakerphone in the room. And so same thing, I have to get the patient talking. I ask the family, what do you guys understand about what's going on? And then based on that vibe that I get of their understanding and health literacy and things like that, I have to kind of meet them where they're at to try to get them to understand, because that's probably one of the most common scenarios where there's a significant discordance, right? Discordance meaning, they think that they're rooting for her. She's a fighter. She thinks she's going to get better. Meanwhile, I'm like, this patient is actually likely to die within the next week or something like that, right? And bridging that gap is a feat to get people to go from one end of that spectrum to the other. And there's a lot of, I would say some communication strategies involved in that, but still not the kind that you can just like teach somebody. That's stuff that needs to be witnessed and experienced. And so I've had a lot. I pretty much always will try to bring learners with me when I have those kinds of conversations, because those things need to be witnessed, and then we debrief afterwards and we talk about what they observed, and then I'll say, here's what I was doing when I said this is why I said it this way, here's the effect that seemed to have. This was a strategy to get this patient to understand that we were at the end of life situation, and that doing more interventions is unlikely to be helpful, and things like that. And doing all that, most situations with like no medical jargon itself is a challenge, because when I witness, sometimes I'll put a student, not a student usually, but a resident, in a position to at least get one of those conversations started so they can get some practice. But it is very common for them to start throwing out a lot of medical jargon. And I immediately recognize that. And so I'll either clarify, and then afterwards we'll debrief, and I'll say, you notice when you said that this patient had hyponatremia? Yeah, that nobody knows what that means, right? We need to, anytime you want to use one of those words, you're going to have to train yourself to adjust your language. And then the last thing I do with patients, aside from understanding my audience, who I'm speaking to, their health literacy, paying attention to the context and adjusting my communication style. Like in those end of life conversations, I'll typically speak more quietly, more slowly, kind of just be generally, more respectful of the gravity of the situation and things like that, compared with, yeah, you're here for pneumonia, you're better, I can send you home today, great news. That's a very different type of conversation. But the last thing that I will often do is some form of assessment of the patient or their family's understanding, and that's just like a basic teach back type method, right? So once we're done wrapping up, I might just actually prompt them or ask them, based on our conversation today, can you kind of summarize your understanding of either where we're at or where we're going or what I'm recommending? And that's also a useful tool it is a very humbling tool, I will say, because sometimes you will go through an elaborate conversation. I'm sure you've had this experience, and then you do something like that teach back method, and they're just like, I don't know. And you're like, damn, I put a lot of work into the conversation, right? So then what does that mean, though? It's like when I'm teaching a learner and suddenly I have to pivot to a different analogy or a different way of explaining things, then I have to do that same thing in that context. So maybe that means I have to take a different approach to explaining it. Maybe I'm explaining it, I have to find some pen and paper and actually like write some of this stuff out, in which case I'm going to write it out in like giant words, just like my PowerPoint slides, like big stuff, like the key high points, reminders, or whatever I want them to take away from it. And then I'll literally do it again. After all that, I'll do another teach back to see, did they actually grasp it this time? And I will iterate as much as possible. If I keep failing, which fortunately doesn't happen terribly often, then I might, try to rope in some other member of their family or somebody who caretaker or something like that to get some assistance with understanding. But I would say that those are the main ways that I approach things differently with patients and in the clinical context, especially in the hospital.
During those scenarios where it's potentially a little bit more morbid, or it's these end of life discussions, and you're watching these interactions with students, residents, and then maybe there's uncomfortability with individuals crying or getting angry at you, what is your recommendation for providers or students during that period of time of being okay with silence, knowing how to navigate the situation when it's uncomfortable? What are your reflections on those moments?
Yeah, that's where I think that, your first one of those should never be when you're a trainee. I think that you should ideally have seen some of these get done by somebody with more expertise or experience in that, because then you'll actually see how those can get done. But when you get the patients and their families speaking first, and you hear their context, where they're coming from, their understanding, their fears, their anxieties, their hopes, if you can get a sense of all of that, it makes it a lot easier for you to kind of put yourself in their shoes a bit and understand why they might be expressing themselves in a particular way, right? So if they get angry or frustrated or anything like that, I think that doing your best to not take that personally, but rather that's emerging from just the overall situation that they're in and how terrible it might be. So kind of like when we talked earlier about conflict between colleagues, and I just have to shut down any sense of like pride or ego or anything like that. There are situations like this where I've had patients or families who were upset for various reasons. Maybe they, took certain things out on me. It might not be for anything that I did right or wrong or anything like that. And literally, I just like completely shut that element of myself completely off. And I'm just like, there's no point in me being prideful or defensive or anything like that here. Ultimately, I'm just here to facilitate this process as best as can, even if that process is the dying process. So making people feel heard, I think, is the best way to have some success there. And making people feel heard does not require that you speak. So to your point about like, getting comfortable with silence, yeah, that's because you should be listening, and you can, make good eye contact and give kind of nonverbal cues and things like that. And there's going to be emotions in those contexts, and kind of recognizing and validating those concerns and feelings. I mean, even outside of end of life conversations, I mean, I've done pain and rehab consults and things like that with people through our other through the barbell medicine side, and people who have, excruciating, debilitating, chronic, back pain or radicular pain or anything like that. I mean, I'm sure you've seen how horribly that can impact people, sometimes to really severe extents, and that deserves to be recognized and validated for them to feel heard. And so I think that it can be tempting for a clinician to just like have something that they want to convey in their mind, and they're so fixated on wanting to say that they don't actually pay attention to what's going on in front of them, right? Kind of like when you're out and about and you're meeting a whole bunch of new people, and you're so worried about what you're going to say next that you actually don't pay attention to anybody's name, and then you forget, right? So this is a scenario where it's like you have to shut your own brain up for a little bit and just like be there with the person for a bit, like kind of share that space, listen, validate, etc., before you tactfully, express what you think needs to be conveyed. And so that's something that, like I said, I could tell anybody this, like anybody who's listening to this who's never had one of these, and put you in one of those scenarios, and you're probably not going to do great at it. And it's something that I think it's kind of one of those, ideally, much more oversimplified method of learning, but the see one, do one, teach one kind of thing. It should be see a few, do a bunch, and then teach a lot. would be a good way to go about that process, because no one of those, no two of those conversations are the same, obviously, right? So,
what about the openness to bringing in questions? So it's, again, context dependent, but how do you, at what points throughout a conversation or teaching do you want people to ask questions, or do you elicit, does anyone have questions, or what are your thoughts? I'm sure like if there's a time component to a lecture, maybe you caveat that questions are going to be at the end, or raise your hand, or if it's teaching a patient, you stop me if you're confused by anything. But what are your thoughts about openness to questioning and allowing people to be aware of when and how to ask questions?
Yeah, I don't know that there's one right or wrong way that I would advise on doing this, and sometimes you need to be able to take different strategies with different people. So in the auditorium setting, my preference is typically to hold questions until the end, not just because of the time kind of pressure, but also just because you kind of get into a bit of a flow, based on the design of your talk, and interrupting that and getting back on track can be sometimes a little bit challenging. I won't say I never take questions during a talk, but my preference usually is to let me get through the thing, and then also have the learners come up to me after the talk, so that the rest of the students are not stuck sitting in the auditorium listening to a question that they didn't have. Just kind of being considerate of people's time in that setting. In other contexts, yeah, I don't know that I take one specific strategy. I think that if there is an extremely key point or something extremely important that I want to convey, obviously, as I said, I will tend to repeat that a few times through the conversation, but it might be a scenario where when I make that extremely important point, that might be a good time to prompt somebody for questions, just to make sure that that has been kind of hammered in. But I'm not terrible. I'm very flexible on people asking questions. Now, if they're hammering me with so many questions that I can't get to the end of my thought, then I might have to pivot. But that's a kind of a real time adjustment that you might make when you're having a conversation with somebody. So I think that there I don't know if there's even like educational methods like research on anything like this, because again, I'm not an expert in that kind of space, but I'm not terribly rigid with how I would go about that. I think just prompting people for questions, or like I said, using teach back methods in certain contexts is a great way to get a sense of whether the message that you are attempting to deliver has been received in the way you intended it.
This may be an entire podcast on its own, so we don't have to dive into it a ton, but this whole conversation was around the teaching process in all of these different contexts. And if you're on the other side of this, if you're the person learning, do you have recommendations on how to be a better learner during any of these interactions?
Yeah. So some things are more within our control than others. For example, like how much do you care about this particular topic? You may not have an intense interest in the topic. It obviously helps to be interested in what you're learning, right? So this is why, I ended up as a nerdy internist, because I like learning and knowing a ton of things. But somebody else who wanted to pursue a completely different path, they might just fundamentally not be as interested in certain things. So ideally, you are attempting to learn or listen to something that you actually care to know about. That is like a good foundational kind of thing. But I think one thing that is underrated, or the importance of it is underrecognized, is that kind of foundational background knowledge in an area. And if you don't have it yet, like if you're a first year medical student, the first task is really to build out that foundational background knowledge. Unfortunately, in many situations, like in first year of medical school, that can be on the tedious side, and it can be a little bit less interesting than you'd like, especially compared with the much sexier stuff that you're looking forward to learning down the road. But the problem is, like I said, when we're learning and expanding our fund of knowledge, you need to have that foundational background knowledge that you can then kind of scaffold additional stuff onto, and then build relational connections from one thing to the other. And so much like the process of physical training, or any other task, like recognizing that this is a much more long-term process, and even though there might be some short-term rewards along the way, it is a very long-term process. Like I said, I've continued learning more since finishing medical school than I learned in school, or since residency than I learned in residency, through both experience and active self-directed learning. Like I end up continuing to read and study, in some ways, actually a fair amount these days. But what I recognized is that it gets more and more enjoyable for me to do that, because each of these new things that I learn now, I am more easily able to relate it to all of the prior knowledge that I have accumulated. So like sometimes, gosh, if you could like pick any symptom right now, for example, that somebody could have, I could probably find a way through just like one tangent into the other to teach you effectively everything I know about medicine. Just pick any starting point and I could connect it somehow to everything else, which, recognizing that, is super cool and feels very powerful. And it makes it easier for me to learn new things, because I learn this new thing that impacts this system, and then, oh, this is that other thing that I recently learned that affects that system, and here's how we would treat that, and here's the side effect of that medicine, and here's the other medicine that can cause that side effect, and that medicine's used to treat that condition, and that condition can manifest this way with this symptom, so you see how like the more you grow and accumulate this stuff, the relations and connections between them get more and more integrated, tightly woven, complex, and it actually strengthens your understanding of everything. And so that's kind of like the big picture learning process that I see. That foundational knowledge needs to happen. The additional layers get integrated and connected, ideally. And so that's why there are certain methods of learning that I prefer less, or that I would say I have a bit of a bias against. I don't want to take too hard of a line against them, because it's hard for me to know which of these were just like not my preferred way of learning and somebody else might do fine with them, versus which of these are like actually worse, right? So, one of the things that I notice and experience is like the transition from when I was, say, going through high school and college and then to medical school and now teaching at medical schools and things like that, is kind of like a very significant digital transition, right? So when I was going through my undergraduate education, uh, my main method of kind of studying was taking a lecture's material and condensing it down as much as I could in handwritten form onto like, a page or two front and back, and then, repeatedly going over that and prompting myself to actively recall that material, and sometimes condensing it more, and then pointing out what are the things that I continue to struggle to actively recall, and then putting more focus on those until the point where it really sunk in, right? So I might have this like handwritten set of condensed notes on things that I might have reviewed, 6, 8 times by the time I have to take an exam on a particular topic, right? That is fundamentally a different way of internalizing studying learning, I think, compared with if you took 6, 8 times where you just clicked the down arrow on your laptop, flipping through the slides from your PowerPoint lecture, right? Reading and rereading passively in that way, I think, is likely to be an inferior way compared with strategies that require active recall and retrieval of the information, ideally in some sort of way that is linked to another element of your knowledge, or linked to something, say, among the residents that I work with, to a clinical scenario. Like, we saw this patient who had this thing. Doesn't that make it easier to remember? I mean, I know that by the time I got to taking my internal medicine board exams, after I finished training, I was just like taking this, relatively long test, and I'd read a question prompt and I'm like, oh, I remember that guy. I saw that patient. Here's what we did, right? And here's why. And knowing that. So the test ended up being like, linked. It was essentially recalling like the things that I saw and did, which made that test not very hard by that point, because I'd had this base of thousands of hours of experience and seeing so many patients with all these conditions, and building that relational understanding of here's what they have, here's what we're doing, here's why it works, and here's the evidence base for that, if it exists. So I think that, from a learning standpoint, recognizing it's a long-term process, I need some foundational knowledge, I need relational knowledge between things, and then that process of active retrieval and recall is exceptionally useful, and I think more useful than more passive methods like reading or rereading, like flashcards. I know that people love flashcards. I've never been a flashcard person myself, but I recognize that for some things they might be useful, but I also don't see a strong way that reinforces that relational kind of aspect of things, right? And then ideally, if you get through that process, the next step beyond that is, can you explain or teach it to someone else? Which is, I guess, kind of the whole thing we're talking about here. Because if you get to that level, then that is your own kind of evidence and proof to yourself that you understand something, right? So I remember getting through all my medical training and residency, and I showed up on the hospital wards for the first time in my first month as an attending, and then I had, residents and students under me, and then I was like, all right, time to teach, hyponatremia, which is one of the most dreaded topics in the world of medicine and nephrology because it's very complex. And I did my best at teaching it, and it was okay. But I noticed while I was saying things, I was like, I don't feel great about the way that I'm explaining this, or this is a stumbling block for me, or, if they ask me why this thing that I just said happens, I'm not going to be able to answer that. And those were all signs to me that I don't know this as well as I should. And so, again, having identified those things and filled those gaps in the ensuing years, building out that depth of understanding and relational aspects of it, now I feel, again, this is a talk that I could sit up out of my sleep at 2:30 in the morning and I could give the talk no problem because of how well I understand it at this point. So I'd say that's my big picture perspective on learning and the approach to it, and what I think are the more useful methods and some of the less useful methods that you can use.
We could probably go on for quite a while because you're so passionate about this, but is there anything as we close out that you either want to summarize or you want to briefly touch on before we close it out, Austin?
Interestingly, I have noticed even while giving some of these answers, I will give this whole exposition and then I notice myself re-summarizing my answer and restating the key element. So I'm doing the very thing in these answers. And so I feel like I've hammered on most of the things that I view that are important, whether as a learner or as an educator. People will have heard me say numerous times throughout this talk things like active retrieval as it relates to learning, or knowing your audience when it comes to teaching, and being able to recognize and be dynamic there. And the better you understand something, the better you're going to teach it. But the best way to get better at teaching is actually practicing it, which itself becomes this like favorable cycle of building your understanding as you teach. So would encourage people to try, if they're interested in this. Just practice is probably one of the most useful things that you can do here. But being very patient and genuinely asking for feedback from your learners is something else that I think ought to be done by more educators. So I do not routinely see a lot of educators asking for genuine feedback from their learners on, you know, tell me what you think I could do better, or anything like that. A lot of times, especially when there's like a pretty large, hierarchical difference or like power dynamic between, it's like beneath them to ask the opinion of a first year medical student on how to explain. It's like, no, because my job here is to get you to understand this, and if from your perspective I could have done this differently or in a better way, I'd like to know. So, I actively seek out my own, evaluations of me. I've worked at places where those were collected, but like not routinely sent to me. And so I like actively sought those things out, and they're like, "Oh, you actually want to see your evaluation?" And I'm like, "Yes, I want to see them," because, I recognize that even when I'm asking a learner for feedback in front of me, they may still be intimidated to tell me what they actually think, right? Because there's just that inherent, dynamic there. Even I could be as nice and patient and gentle, and they might just still not want to really tell me, "I didn't love this," or "This made me feel, not great," or whatever. And I want to know these things. So I think practicing, eliciting feedback, incorporating that feedback, and then all the other strategies that I talked about will, at least based on my uh, uh, I guess research evidence-based experience, seem to work pretty well, as evidenced by my track record, I guess, to date. So yeah, thanks for the opportunity. I had fun talking about all this.
Of course. Yeah, I think it'll be very helpful for the spectrum of people, whether it's clinicians talking with students, whether they have or CIs, clinical instructors talking to their students, talking to patients, a physio or rehab professional that wants to go into teaching in an adjunct role or an actual professor. Like this, as you've said multiple times, it's applied across the board, but knowing the context and the scenarios, things need to be shifted a little bit. But yeah, I thought this was a great conversation. We will call it there. We'll put your information in the show notes. Thank you so much, Austin.
Yeah, thank you. Appreciate it.